Now it's my pleasure to introduce Chair of the Day, Tony Battaini, who will introduce our speaker.
So when I signed on to do the reflection, I didn't know that I was going to have my guest speaker here today, so that's why I'm doing both tasks. Just a little bit of background. Some time ago, I was doing work at the University of Melbourne in the medical faculty and became aware of an organisation called the Australian Venom Research Unit. And when I joined Rotary about a year ago, a little light bulb went off in my head. And so I contacted the university and said, how's the, as we call it, the AVRU going? And they put me in touch with Andrew. And so Andrew's going to talk about the work they've been doing up there in Papua New Guinea. And it'll give you a bit of a context. Our club is going to get involved in this, and initially in a small way, but it'll give you a context of why we're going to get involved and what the value is that we can bring. So Andrew is a medical researcher with a background in neuroscience, clinical research and public health. He has his PhD from University of Melbourne. That was in 2014. He joined the AVRU in 2017, and for some years, from about 2019 until recently, was involved with, he's a co-head there who's involved with the PNG Snakebite Partnership, and he'll talk to you about how that's evolving. He's handed that responsibility over recently to St John Ambulance. His research focuses on the application of epidemiological data to drive clinical improvements for snakebite patients. And post-COVID, no one needs to explain to anyone what epidemiological means. They're now heroes. Using regional snakebite incidence data, Andrew's worked to ensure local hospitals and health centres have adequate supplies of life-saving anti-venom across PNG. So welcome, and we look forward to your presentation. There will be no live snakes, by the way, so that's...
Thanks very much for that introduction, Tony. And thank you for having me. I'd like to start off, if I can, by just acknowledging the traditional owners, the Wurundjeri people of the Kulin Nation, and pay respects to their elders, past and present. As Tony mentioned, my name's Andrew. I'm the co-head of the Australian Venom Research Unit, and I'm here to talk about snakes. You probably know a little bit about snakes living in Australia. Some of you have more personal experience than others. Gary, I should have asked you this beforehand, but it's not often that I'm in a room giving a talk where somebody knows somebody that's been bitten. It's a fairly rare occurrence in Australia, but we do have a relative of a bite patient here who thankfully survived. We only have about 600 bites a year in Australia, and of those, only 2 people die. The story is very different up in Papua New Guinea, though, and having a look at a road, this is a road to Moragwina, which we'll touch base on later. Having a look at the grassland and the bush essentially next to the road, it's not hard to understand why. The overlap of where people live and where snakes live is much, much closer. And as a result, PNG has one of the highest localised snakebite rates in the world. In fact, it's so bad that the mortality from snakebite up there is thought to be 3 times higher than from diseases such as tuberculosis or malaria, which tend to garner a lot more attention. As Tony sort of mentioned, snakebite tends to be neglected for a number of reasons. Now, a piece of good news for PNG is that they actually share a lot of our venomous snakes. About 50 to 60,000 years ago, there was a supercontinent called Sahul, which I think we can all agree is a fantastic name. And if we ever go for a rebrand, that's my vote. There was a land bridge between Australia and Papua New Guinea and Indonesia, which essentially allowed migratory patterns for peoples and the indigenous peoples to come down to Australia and sort of travel across. And it also enabled our flora and fauna to sort of kick across the region as well. As a result of that, they've got a number of our venomous snakes, as well as wallabies and other bits and pieces. The reason that I say that's good news is because they have our venomous snakes, it means that we can take Australian-made antivenoms up into Papua New Guinea, and they work very, very effectively. CSL Seqirus, who Matt Wenham is a representative of today, makes some of the world-leading antivenoms, and thankfully they're effective both in Australia and in Papua New Guinea. I want to give you a bit of brief history, though, because I only joined this project in 2018, but CSL has actually been trying to get something off the ground in Papua New Guinea for a number of years. So back in 2009, they actually commissioned a report from the Nossal Institute to have a look at snakebite and the impact up in Papua New Guinea. And the review looked at the period from 1990 to 2009 and basically found that deaths were increasing as a result of a decreasing availability of antivenom. So one of the big challenges up there at the time was that there was no central store, there was no central National Department of Health fridge. Antivenom is a cold chain product, and what that means is it needs to be refrigerated to maintain its efficacy. There was no infrastructure, as you could see from some of my earlier pictures and this picture of the Eastern Highlands. It's a very, very logistically challenging environment to work in because the roads aren't necessarily great and some of the areas are particularly remote. And one of the big factors is also the cost of antivenom is quite high. So each vial is currently worth about $2,500 to $3,500 Australian dollars, which means that you get a lot of slippage out of the program if you're not keeping an eye on things, and it ends up on the black market, getting sold for about 3 times as much. PNG Department of Health tried to change things up in 2014 by purchasing antivenom from CSL. I say purchasing, I'm not sure whether the invoice was actually paid, but the antivenom was sent, an invoice was sent as well. And they bought about 250 to 300 vials a year for a number of years at a worth of about $500,000 Australian dollars. It wasn't quite hitting the point though, and subsequent reviews found that the antivenom still wasn't reaching the public, the people that were being bitten out in remote communities, and there was still too much slippage. So in 2017, CSL sent representatives up to sit down with the National Department of Health in Papua New Guinea and the Australian High Commission up there to formulate a plan. And what they came up with was a model distribution project called the Papua New Guinea Snakebite Partnership that centered around CSL donating an annual donation of 600 vials of antivenom. And on the 1st of April 2018, the Australian High Com, CSL Securus and PNG Department of Health launched that project, of which the University of Melbourne was the project lead. So I joined in 2018 as the project manager and took over a project lead of the partnership in 2019. And you can see from that this is a pretty big international collaboration. It's got some heavy hitters, 2 governments, Australia's largest biotech, and 2 universities. If you love bureaucracy, you're going to love this work. The Snakebite project has a very, very simple aim, and that's to increase the distribution, improve the access, of life-saving antivenoms across Papua New Guinea. And we have 3 core pillars that enable us to do this. The first one is simply distribute antivenoms across the country. A bit of a no-brainer, make the medicine available. But you can't just take a medicine out there, particularly not something like antivenom, which requires specialised administration, without training. There's no point putting antivenom in a fridge in a health centre if nobody at the health centre knows how to administer it, how to check to see whether a patient's been bitten, or how to monitor for any adverse effects that may come from antivenom. Antivenom is a biological product. It's horse plasma, essentially. It's still a pretty old school thing. We're using the same formula for the last century. Which means that clinically we know how it works, but we still have to teach others how it works and how to monitor it. And the third one is, of course, figure out how big an impact the program's having and how big an impact snakebite is having in Papua New Guinea. So the third pillar there is collecting data on actual snake bites and the use of antivenom. And I'm up here talking to you today. I was the project lead, but realistically, all the credit for this program and the work on the ground is due to our 2 local staff. So we've got Geno Rolakona here, who is our project manager and pharmacist, and really the brains behind the logistic aspects of the operation. And then we've got Andrew Maru. He's our snakebite nurse and clinical educator. He's the person that you want at your bedside if you ever get bitten in Papua New Guinea. Of course, I dare say if you ever get bitten up in Papua New Guinea, something else has happened terribly. But nonetheless, you want him there by your side. Let's talk about snakes. Do you want to take a guess as to what type of snake this is? This is one of the main snakes that we deal with up there. Any budding herpetologists in the room? What was that? Tiger. Oh, it's a good guess. They don't have tiger snakes up there, but I'll take it. Popular in Melbourne. I believe there was one in Flinders Street a couple of years ago. This is a taipan. This is the main snake that we deal with in Central Province up there. Oxyuranus scutellatus, for those of you playing Latin. Scutellatus is how I remember it because it is an aggressively defensive snake and it will come at you if it's nervous and feels like it's being impinged upon in any way. They're very, very common in the savanna grasslands. They're alert and shy and a nervous snake. And a nervous snake is a dangerous snake because it means it's got a bit of an itchy trigger finger. And when a taipan gets defensive, it tends to go on the offense. And so if you're going to get bitten, a lot of the time you're going to get bitten multiple times by these snakes. So they're extremely dangerous if approached. They average 1.8 to 2 meters in length. Horrifyingly, they can get up to 3 meters in length, although I haven't seen any of those in person. Nonetheless, best to steer clear of them. You can see by the pictures that they have different colorations depending on whereabouts they are. They've got a lovely iridescent copper color or quite a dull matte black color, which means that we do get quite a bit of variability in terms of people's descriptions of what type of snake they were bitten by. So we tend to rely on the clinical side of things to map it out. If we have a look at the map, the orange regions are where this snake is located. Pretty much the entire coastal region. The question mark there around the Gulf province around Kerema, that's simply because we haven't done any mapping in that area. We're pretty confident that it's going to be stretching along that coastline as well. The other main species that we deal with up there is the death adder. It's a sedentary nocturnal snake. You've probably seen these. These are a pretty widespread Australian species as well. They're what we call an ambush predator in the sense that they'll find a nice bit of leaf litter. Their tail has a nice worm-like appendage on it, which they'll try and use to get something to strike at, and then they'll strike at them. They've got an average length of about 0.5 to 0.6 meters. They never go over a meter, which is good. And they're very, very common in the forested areas. We tend to find that most of these bites occur on the feet because it's generally from people not seeing them in the leaf litter and stepping accidentally on the snakes. And as you can see from the pictures there, the colours are highly variable depending on the regions that they find themselves in. They are everywhere in PNG and across into West Papua as well. There's not an area that we don't find them. How do we distinguish clinically? We use the two different toxins that are the core, the clinical syndrome that we see from these snakes. And there's two main types of toxins that we deal with up there. The first are the hemotoxins, which just means blood toxins, essentially. And in these snakes, we're dealing with procoagulant toxins. So they result in bleeding at the bite side, blood in the urine, vomiting blood, bleeding gums, and those kinds of things. Thankfully, there's differences between taipans and death adders, which makes our job a little bit easier. Taipans have a really strong procoagulant activity, so we tend to see more bleeding from taipan bites. Death adders have very weak activity. So you might see some bleeding at the bite site, but you're unlikely to see blood in the urine or blood in vomiting and those kinds of things. There are other snakes up there, such as they do have brown snakes, black snakes, small-eyed snakes, which do have overlap in symptoms. So we try and be as definitive as possible. Obviously, working in an infrastructure-poor environment, we have to use pretty simple measures. Thankfully, we've got this wonderful test called the 20-minute whole blood clotting test. And how this works is you literally take a glass vial. It's usually an old penicillin vial that's been rinsed out with water. You take 10 drops of blood from a bitten patient, and you pop those 10 drops into the vial, and you pop that vial on a bench, and you wait 20 minutes. And if at the end of those 20 minutes, you turn that vial upside down and the blood runs as if it was freshly drawn, that's a positive test. And with taipans, we'd expect to see that. It basically means that the blood's not being able to coagulate or clot in the vial. If it clots and it turns to jelly or something similar, that's a normal test. So we can be pretty certain that's going to be a death adder or another bite along those lines. The basic rule of thumb is if you turn up with any form of neurotox and you've got a positive 20-minute blood test, that's a taipan bite, and we'll give taipan antibody straight away. Neurotoxins are the other ones. We assess these from the head down. And what I mean by that is we start from the eyes and we work our way down to the respiratory muscles. The neurotoxins basically bind and neutralize the muscle fibers. So ptosis is a drooping eyelid. So very, very small muscles of the eye. That goes down to ophthalmoplegia, which is the movement of the eye. And then down from there, tongue protrusion, the ability to stick your tongue out. If you can't put your tongue out past your mouth, that's the musculature of the tongue and so forth. The reason that we start from the head down is if we catch it at the eyes or the tongue, it means we can get the antivenom in there before it hits the lungs. If we hit the lungs, we've got a bit of problem, particularly if it's taipan, because taipan's neurotoxins bind irreversibly, which means once they're bound, and no amount of antivenom is going to get them off. So if you come in 7 hours after a bite and it's already in your respiratory system, we can give you the antivenom and that's going to get rid of the hemotoxins, but we're also going to have to provide life support in terms of sedation and intubation. And that just means knock you out, pop a tube down your throat and into your airways so that we can breathe artificially for you. And look, you're going to be fairly comfortable there, apart from a bit of a sore throat when you wake up in 7 days' time, but after that, you'll walk out more or less okay. Thankfully, death adders, the neurotoxins in death adders bind reversibly. So it's a nice little trick that we can use. There's a medication called neostigmine, which is an anticholinesterase. It doesn't need cold chain, so we can have it out at more remote facilities. And this stuff's great. You basically take a little bit of neostigmine and you have someone that you're not sure if it's a taipan bite or a death adder bite. They've got the drooping eyelids. They can't poke their tongue out. They may be having a bit of trouble speaking. You give them neostigmine, about 30 seconds later, all of those symptoms are completely gone. Now, it doesn't fix the underlying envenoming, but it tells us immediately that we're dealing with reversible toxins. So therefore, it's a death adder bite. We can give the death adder antivenom and send them on their way after 24 hours of monitoring. What antivenoms do we actually take up then? Well, look, we get death adder specific ones and taipan specific ones, of course. We've got sea snake antivenoms and snowfish antivenoms as well. And we've got what we call a polyvalent. Poly just means many. Valent means kind of against. So it's against many snakes. If you get bitten by anything in Papua New Guinea and have polyvalent, you'll be covered. But we tend to use the specific ones if possible because they're more effective and they're safer. Our antivenom distribution program, despite only being 3 people and 2 on the ground, we have a huge reach. In 6 years, so this is since 2018, we have distributed 2,726 vials of life-saving antivenom across the country. That's across 73 different health facilities, 630 deliveries all up. We will take a bus, we will take a bike, we will take a canoe, we will take a single prop airplane. There is no mode of transport that our team hasn't taken to get these antivenoms out there. And I think we're in 13 provinces or states up there now, which is fantastic. And again, only with cold chain facilities. Of course, we are only a small team, so we rely on partnerships. We're very, very good at networking and finding friends who we can work with and upscale both of our activities. So we work with St John Ambulance, Youth with a Mission. That's the YWAM ship. That looks like a luxury cruiser. That's actually a hospital on a boat. They do dentistry, optometry, all that kind of surgical interventions, and we give them antivenom and training as well to take along that southern coastline from central across into Western Province. SCP Aerial Patrol are flying doctors, which we do follow them on their routes and make sure they have antivenom so they can do drop-in visits to centres which don't have cold chain facilities. Kokoda Track Foundation, Manalos and more. If you have any other contacts in PNG that we don't have listed here, please grab me afterwards. We are always looking to expand our friendship circles. Of course, there's no point going to any of these health centres unless we're also training. So every single dot on this map also had training undertaken at that centre. And this is Andrew, our nurse. He's currently teaching a pressure immobilization bandage. That's your first aid of choice. If you get bitten by a snake, firm pressure bandage from the extremity of the limb all the way up as far as you can go, and then stay still and let the ambulance come to you. This is in a place called Moriguina. So far since 2018, we have trained up over 1,500 healthcare workers across the country. Of course, the difference in facilities is going to be pretty variable. So this is the state-of-the-art facility in Kupiano. It's a district hospital, which is literally just being built. So this is one of our nicer facilities that we deal with, and a bit of an outtake from the Moriguina. Some of them are a bit more rustic. So we deliver our training based on the minimum of infrastructure to make sure that our impact can be as high as possible, regardless of the remoteness of the facility. Basically, all they need is a syringe, a needle, and a fridge, and we can make sure that they can give antivenom in that facility. We also monitor snake bites. No point taking all this medicine out if we're not seeing if it's having an impact. We're working with paper forms, which, look, in Australia, it's hard to get doctors to do their paperwork normally, particularly on a paper form. If you're talking about PNG, where we've got some really remote sort of different areas, it's phenomenally hard not only to get the forms out there, to get them filled out correctly, but then to go back and collect them in some capacity and digitise and analyse. We've sent around over 5,500 forms so far. And from that, we've worked with the Department of Health to formulate a database of 2,357 snakebite patient forms, which have been returned from 44 of our 73 health centres to date. This represents the largest snakebite data set in the region by far. And we're currently working with the Department of Health to essentially publish this in the scientific literature and to highlight the impact of this work. These patient forms represent 2,284 patients because we track transfers as well. And we had a couple of duplicates, which is a little bit annoying, but I'd rather get it twice than not at all. More importantly, they represent over 1,000 vials of antivenom that have been administered, representing more than 1,000 lives saved by this program to date. We also track where they are. We get a whole lot of clinical data, age, demographics, those kinds of things, where the patient was bitten, what they were doing. We can tell you that 90% of bites occur on the feet, ankles, lower legs. So most people are getting bitten accidentally while outside, just doing their normal day-to-day activities. A lot of people just gardening, subsistence gardening and those kinds of things for their fruit and vegetables. So, which means that preventative training and education about how to prevent bites is a huge part of something that we can explore as we go through it. So that's what we've done to date. So we've got over 1,000 documented lives saved by this program to date. We can estimate based on the number of forms that have come back so far that we could probably safely double that to 2,000 lives saved. And we've trained over 1,500 healthcare workers. So it's a pretty phenomenal effort for a pretty small team. Let's keep this track record going though. So we left off at 2018. We've covered the last couple of years of the program, but in 2023, the University of Melbourne actually decided to step down from the project. They gave me one more year to find an in-country partner, and with CSL Securus and with the National Department of Health and the Australian HICOM, we tracked one down, and we've decided to hand over, and have recently handed over, as of March this year, to St John Ambulance up in Papua New Guinea. Something else great happened last year, and that's Anthony reached out to me, as he mentioned before, to discuss some potential support from Rotary and how we could engage with your collective. St John, quickly, so this is, you can see just from this picture that they have a lot more resources than our single Snakebite ambulance. They've got airplanes and a fleet of ambulances, as well as two bases, one in Port Moresby and one in Lae. That's their Chief Medical Officer, Dr. Mango Candino, over there. And this is Dr. Arabella Colowan, who's the Clinical Systems Director for St John Ambulance. And you'll probably notice a couple of familiar faces here who met Arabella last week, I believe, at the World Health Summit that was held in Melbourne. So we're making those connections already. We've been talking to Tony and Peter and others for about, I think the best part of 6 to 8 months now. And during these conversations, our focus has largely been on, look, I work in snakebite, but mainly I work in public health. And so what we really want to do is not just go in there and target snakebite and hit a niche in the health system, but see what we can do that impacts snakebite while also raising up all other public health in the area. So we've talked about the notion of cold chain and perhaps getting solar fridges, the importance of training, both community healthcare training as well as preventative training, as well as community sort of education programs. And we've talked about the use of medical equipment and the importance there, essentially, particularly ventilators. And it's ventilators which we've really come back to time and time again. I want to show you this map. This is the southeastern corridor of Papua New Guinea in Central Province. We've got Port Moresby just here behind me, down to Kupiana. It's about 200k between Port Moresby and Kupiana, but given the roads that we saw a little bit of earlier, it's about a 7 to 8 hour drive in a 4-wheel drive. It's not a bad way to spend a day if you're just delivering antivenom. It's much, much nicer than my office at Uni Melbourne. And I don't mind it, to be honest. As long as you know where the potholes are, you're pretty much covered. The challenge we find, though, is when you've got a patient that's been bitten by a snake in Kupiana or even Moraguina or further down in Magabao that needs to come up through this corridor, supporting a patient's airways on a bumpy road in the back of an ambulance that's not necessarily kitted out is phenomenally difficult. And what we realised that if we can add some training and support at a bottleneck in that region, we could potentially save a lot of lives. So late last year, we lost 4 patients in this region alone who had received antivenom, but unfortunately didn't have the appropriate airways support. They were being manually bagged. And what that means is we had a tube in, but we didn't have a ventilator. They literally had somebody sitting next to them, squeezing a bag to get air into their lungs. Very, very hard to do that whilst hold onto a seat, whilst not vomit in the back of an ambulance, while somebody else is driving at breakneck pace. So we identified Coquilla as a bottleneck. And, oh, here's a road. Hopefully this video will work. So this is the road to Moraguina. This is a 50k track. I've never seen this road in better condition. It's 50 kilometres. It took us 3 hours to traverse. But imagine being in the back of this with a tube down your throat as somebody's trying to give you oxygen. It's a very, very, very tricky thing to do. This is the only road into Moraguina. So it's a very, very different environment that we're working in. This next slide is simply a thank you. So we identified Coquilla as a hotspot, and Tony's been working behind the scenes to really get stuff done. This is Coquilla District Hospital. It's the largest hospital in the region. It's a bottleneck for every region beyond that. Kupiana, Moraguina included rather. And Tony and his work and Peter and others have recently secured 18,000 from Rotary Melbourne to purchase a Zoll ventilator to put in at Coquilla. And the reason that this is important is this is a portable ventilator, which means that we can get it in an ambulance at Coquilla, and we can drive it out, and we can intubate a patient on the side of the road between Kupiana and Coquilla, and then that portable ventilator can travel with them into Moresby. Or it can go back to Coquilla and St John can match them at Coquilla Hospital. And we can simply trade over a ventilator that's not currently in use, and that ventilator can stay with the patient before they're taken off down at Port Moresby General Hospital. So we're obviously keen to continue our discussions. I'm keen to put you in touch with St John and keep these going for additional conversations around training and other aspects as the dust settles with St John taking over. We've saved 1,000 lives to date. We look forward to seeing how many more we can save with your support. Thank you so much for your time.
Were there any traditional remedies or treatments prior to antivenoms?
So we do track traditional remedies. Yes, and it's very varied depending on which region it's from. I was talking to Chris a moment ago. Papua New Guinea's got one of the most culturally diverse, it's the most culturally diverse country on the planet. It's got about 600 to 800 different languages that are spoken across. And so depending on the region, you've got very, very different traditional practices. The way that I view it is if the practice is doing no harm, I don't mind it. How do we incorporate it into what we're doing to keep those cultural practices alive? The main one is black stone, like just simply placing a black stone on top of the wound. Absolutely no problem. Do you know what? Put a bandage on first, put the black stone on top of that, go to the hospital, you're absolutely fine. Where we run into trouble, though, is where they're damaging. So scarification is a big one. So it's where they cut the wound. The reason that that's a problem is not only are you using potentially a rusty implement to cut someone, but the venom's not necessarily in the person. Not every bite is an envenoming bite. A snake might give you what we call a dry bite, which is where they don't inject venom at all. They don't even attempt to, or they may miss. They may hit you, get a little bit of venom, but then miss, and some venom's on your skin. So if you come out with a knife and then cut a whole lot, you've envenomed yourself, essentially. And things like tourniquets as well, which also cause a massive amount of danger. So yeah, we are tracking that as well, and we're working with the Department of Health to figure out where the line in the sand is, I guess. If you don't have another question, I'd love to tell you one final story, because we deal with numbers, but what's at the center of these numbers are people. I want to tell you about a story about this 11-year-old kid called Ben. Ben's not his real name, but I feel like he needs a name, so let's call him Ben. Ben was bitten on a path near his village. It had been raining the day before, but it's in the tropics, so the mud was slippery on the path. It's mid-30s, about 80% humidity. He's wearing shorts, no shirt, no shoes, walks around a corner, and a taipan slithers across the path. Understandably, he gets a bit of a shock. He misses his footing and he slips sliding down the hill towards the snake, which takes that as a bit of an aggressive stance and proceeds to bite Ben 3 times on the abdomen just above the groin. Ben walks back down to his village where he finds his father. They go to the local health centre. There's no medicine there because there's no fridge there. So Ben and his father walk for the next hour to the next closest village, where there's often an ambulance. They go to the health centre. The ambulance is out on another call, so they wait for a little while until they decide to walk one more village across and catch a PMV, which is an open back truck. So that takes another 2 hours. By the time they get on the truck and into Port Moresby General Hospital, it's been 7 hours, and Ben's father's carrying him into the emergency ward. Here's where it's great. Within 5 minutes, we've got him in a bed. Within 6, we're running his blood. Within 20 minutes, we know he's been bitten by a taipan. Within 25, he's got antivenom running through. Within half an hour, he's been intubated and sedated. That afternoon, I get on the plane back to Melbourne. I've never been more conflicted about my job, and I've never followed up on a patient more. What's great is 7 days later, Ben walks out of that hospital with his father. We've got about 1,000 cases like that. Everyone different, but everyone the same. You can't underestimate the impact that this work is doing. Snakebite's not like another disease where it's easy to prevent in some cases. There are certain things that we can do. With COVID, we wore masks to prevent it. With snakes, if I can't afford shoes and I have to go gardening to survive, it's nature's unlucky lottery. And so we need to make sure that we're protecting the people that are being impacted by it.
Quickly.
Congratulations on the speech. Can I just be a bit clearer on the data? Rosemary Nixon's in this group, and she want to know the longitudinal data.
Sure.
You talked about efforts you're making to get paper together.
Yes.
But do you have a sense of what the trend has been and whether it's been reversed by this program?
So one of the really tricky things is there was no data before this. This is kind of the baseline, unfortunately. The World Health Organization, I think back in 2015 maybe, put out a report that said the mortality rate or the mortality level was between, I think it was about 1,500 people a year, but that was based on a very small subset of patients that attended Port Moresby General and a few sort of regional facilities. PNG's never had snakebite data collected in this manner before. So we don't know. We can track to see how the training is going, and we can track to see how effective the antivenom is at saving lives once it's in the system. But in terms of comparison to baseline, it's really tricky. What is interesting though is we can tell, we can have a look at the years. Is there certain seasonal times of the year where you're more likely to get a bite? Are there certain age ranges which are more likely to get bitten? Across the year, it's pretty consistent. There's no time, it's subequatorial tropics. Every time of the year is a great time of the year for snakes because it's nice weather. So there's no time of year that you're not likely to get bitten. But if you're young and you're a male, you're much more likely to get bitten. One of the reasons for that is a little bit more foolhardy. I mentioned a story, I think, to a few of you before that we had a case that was quite an interesting, I get flicked every interesting case to make sure that we're not missing something. There was a gentleman who got bitten twice, once on each leg. And that's unusual. And so we broke it down, and my nurse looked into it. I said, okay, what's happened here? Essentially, the guy had been riding on a bike. He'd ridden over the snake, and the snake had bitten him on the left leg. I said, oh, that makes sense. So then he went to the hospital, but how has he got bitten on the other leg? He said, oh, the guy got angry, so he got off his bike and he chased the snake and he tried to kick it. And he missed, and so the snake hit him again. If the first bite was a dry bite, the second bite certainly wasn't. But it's stuff like that. It's making a decision in anger. It's putting your hand into a hole where you can't see. And we find that men between the age of 20 and 40 are much more likely to do that. And so that's part of the community prevention side of things. Maybe we sort of focus on that sort of area.
Let's give a round of applause to Angela. Each of our speakers gets a gift. I think you've been here once before and seen this. These are socks, Rotary Convention socks. Phil Enderby has provided those. The writing here says 200% Australian. That's each sock, I suspect. And they'll go really well with those boots and probably protect you from snake bites.
Perfect. Couldn't ask for anything more.
Thank you.
Thank you so much.